Hello and welcome to the EMJ podcast with me, your host, Dr. Jonathan Sakia. Today we have the pleasure of being joined by Dr. Laren Tan, the Varner J. Johns Endowed Chair as Associate Professor of Medicine, Chair of the Department of Medicine, and Associate Dean, all at Loma University Health in California, a place that I visited a number of times many years ago. Dr. Tan earned his bachelor's degree in cytology from Loma Linda and his MD from the same university. He then completed his residency in internal medicine and a fellowship in pulmonary and critical care at the University of California, Davis. Additionally, he obtained his MBA in 2021 with a focus on healthcare, marketing, and leadership. And it will become very, very readily apparent to you that this is one very well-educated and very dedicated chap. In 2015, Laren became the medical director of Loma Linda University's Hyperbaric medicine program, which is the first and largest in the region to achieve national and international accreditation by the Undersea and Hyperbaric Medicine Society in 2017. And that same year, he also took on the role of medical director of Loma Linda University's Hospital Wound Operations Services, focusing on establishing the medical center as a leader in wound care. And they rapidly recorded over a year of below benchmark pressure ulcer prevalence. Laren's also deeply involved in entrepreneurship, intrapreneurship, precision marketing, innovative healthcare solutions, and we're going to cover those. He's the chief and creator of the Center for Innovation and Promotions within the Department of Medicine at Loma Linda, and it lauds the achievements and high-quality work of the medical staff. Additionally, he founded and serves as president of Ignis Medical Innovations, a think tank, if you will, dedicated to addressing local and global healthcare needs. Laren's presented at various prestigious forums, including the American College of Chest Physicians, the California Thoracic Society, the American Lung Association, the Inland Empire Health Plans, Riverside County events, and programs organized by the Office of the Mayor of Riverside. And that's the area of California in which Loma Linda sits. He's also an active participant in discussions on California's medical policies. And it's astonishing to think this, but he does have some spare time. And when he does, he tells me he's a closet runner. I'm not entirely sure I know what that is. But then he told me he has a unique hobby of tumbling rocks. And I'd never heard of this. And he's going to educate us. So Dr. Laren Tan, welcome to the podcast. Real pleasure to have you here.
Jonathan, it's such a pleasure to be here and to be able to be on this wonderful podcast. Hearing you speak about all these things, boy, it makes me feel very tired.
It made me tired bloody well reading them, I have to tell you. You know, Laren, I try to get to know people before we do the podcast, just so that we achieve our goal, which is that this should look like it should be a conversation between colleagues and hopefully friends, challenging each other, learning from each other. And I'm going to start with the last thing I said. You told me that you like tumbling rocks, and I had absolutely no idea. I clearly must have missed that lesson at school. Tell us about rock tumbling.
You know, rock tumbling came about. I didn't even know what it was until I'm sure you and many of those that are watching experienced this during COVID, where we were kind of stuck at home, not able to really do too much or go to open spaces such as the beach or go on hikes just away from everybody. And I've got 3 kids. And as you can imagine, they drive me nuts at home. We need to have them to do something. And so, you know, browsing through Amazon at the time and rock tumbling came about. And I had no clue what that actually was. So as I read a little bit more on it, it's really taking rocks, putting it in a tumbler, putting different grits of sand or powder form to where you start to form it, and you start to shape it, you start to polish it, and then you come up with something really shiny. So you start with something that is rough and imperfect in a lot of ways, give it a lot of time, and it comes out to be something more beautiful. I see that in a lot of things that we do, and even as myself, and it taught me patience. So that's just been something that as a family, we continue to do. And quite honestly, it's really just me now. Everybody's just lost interest. But I enjoy tumbling, and I actually brought just what a finished product could actually look like.
Oh,
You
wow.
know, and it started out. This is just being polished. Now it could take months, up to a month, or even a little bit over a month, because I'll just keep polishing and polishing and polishing it until you get something that's just so fine and smooth, and it's great. I've really enjoyed it. It's taught me a lot also.
So you have a special, you don't like sequester the family's tumble dryer, and you actually have a separate device for doing
Yeah,
this.
it's I'm not endorsing any company as a whole, but I got it from like a National Geographic little kit and ended up buying more grit and more sand. And I didn't get a chance to take a picture of the little station that I created in the garage, and I had to create a sound barrier, so to speak, with styrofoam because it's just tumbling, and you'll just hear it rumbling and rumbling as the rocks are rolling.
And how long on average to take a typical rough stone and make something that pretty?
This one took about a little over a month. Yeah, it's not.
24/7. So
Yeah, it's
just,
not overnight. It's just tumbling. Yep. You set the days, how many days you want it to keep tumbling. And then once it's done, you take it out, wash it, rinse it, take out all that grit, put some more grit in, put some more water, seal the tumbler, and just let it keep tumbling.
wow. Wow, that's absolutely fascinating. If you can provide us with some links and stuff, and maybe some photographs of your rocks, we'll stick them in the show notes. I'm fascinated. I love hearing about, the different things that a friend of mine uh, told me that he was into 3D printing. This was a number of years ago, and I thought he was taking the mick. I'd never heard of 3D printing. I'm not entirely stupid, but pretty stupid. And he showed me that he had one of these kits for doing it at home, and he made stuff with his kids. It's absolutely fascinating. Anyway, well, let's get on to the
Yeah.
medicine stuff. What initially took you into the field of pulmonary and critical care? And your work in hyperbaric medicine specifically fascinates me as a pilot. I attended a center in Florida years ago where they used their chamber to do aviation decompression training. And using the pilot's lexicon, if you will, you know, give us a flight level 300, which translates to 30,000 feet. Give us a 30,000 foot view of the role of hyperbaric medicine chambers today. Because I know of its use in wound therapeutics, healing difficult to heal wounds. But I remember it being suggested that it was going to cure MS and Lord knows what else. Well, tell us, the floor is yours.
Well, Jonathan, it's fascinating. When I first joined Loma Linda, that was one of the roles that you had mentioned, that it was an opportunity to be able to, again, I guess we could say kind of like rock tumbling, take something, shape it, and then just see what we were going to end up with time. And for those that are listening that are not too sure about hyperbaric, essentially you're in a chamber, whether it's a multi-place chamber where multiple people can fit in, or a single place chamber. And under intense pressure, we're putting in 100% oxygen. And the theory and exactly what we're thinking about is based upon multiple laws of physics, we're actually able to hyperoxygenate the plasma that blood is actually floating in. And therefore, not only are we oxygenating the organs with red blood cells, but through the plasma itself. So it's fascinating to be able to see all the various different diseases that hyperbaric can actually treat. Decompression sickness is something that always comes to mind, right?
You don't
So
have too many scuba divers, though, in the inland empire.
no, we actually don't, but we're close enough to the coast. And since our program is really one of the only that's 24/7 open to take just any critical illness that's related to hyperbaric, so we'll actually get military personnel. We're one of the sites for military personnel to be flown in. Um, and like you were saying, also, we've got a lot of special forces that do a lot of training in the desert. And from high altitude dives coming down, if they needed actually to be decompressed, they would come over here to Loma Linda too. So decompression is one of them. Carbon monoxide is something, I don't know if in the UK it's something that you experience, maybe not so much, but for us in some of the surrounding areas, uh, heating can be very expensive, especially during winter. So there's some people who actually burn things inside of their apartments or in a tight space, and that results to carbon monoxide poisoning. There are actually some very fascinating indications, especially when it comes to wound care, like what you had mentioned too, that have found to be actually very helpful, especially for people who can't get adequate oxygen to where wounds need to be healed appropriately.
Fascinating. Um, so, moving on to, I guess, one of the main thrusts of today's conversation. Um, Dan Buettner wrote about the blue zones. I saw him give a talk years back. Very, very impressive. He wrote about the blue zones, places on Earth where lifespan and health span were longer than elsewhere. And Loma Linda is one of those places, somewhere in Japan, Osaka, I think it was, Sardinia, blah, blah, blah. But Loma Linda is one of them. And this year, you were the lead author of a paper in the Journal of Healthcare Research called Navigating the Healthcare Conundrum: Leadership Perspective from a Premier Healthcare Organization in Loma Linda's Blue Zone. And you stated that soaring healthcare costs and diminishing reimbursement rates, hospitals and physicians face an unprecedented challenge, providing excellent patient care while maintaining financial sustainability. Give us an overview. It's an excellent paper, and it's a topic that I want to expand on as we talk about the systems in the UK, the US, and elsewhere. But give us an overview of your key observations from that paper, if you would.
Jonathan, that paper was a blessing in a lot of ways. It was able to bring together a lot of the senior leadership in our institution to come together and really put our thoughts down on this paper. Imagine we are all trying to throw this lavish party on a shoestring budget. And that's exactly, I feel, where healthcare is today. It is, I don't think it's unique to just Loma Linda. What makes us unique is what you had mentioned, this blue zone designation, so to speak, where we have a multitude of those that are above 80 that are still living healthy. And I use that as a way to be able to highlight this issue, that where would we be as an institution if we're no longer present to be able to take care of those that are considered in the blue zone? I mean, granted, we take care of much more than just the blue zone, but how is it that we can take care and provide this excellent care while we're getting bombarded with cuts on reimbursement, while healthcare costs continue to increase? We've got inflation that's going around that's felt globally. All these various different things, let alone also, most recently with various different cyber attacks. All these things just keep piling on. And yet the expectation, I would say, which is rightly so, from our community is, I expect to have the best healthcare possible. But what's missing is that people don't realize there's a cost that comes with this, and it's not getting any better.
I think that's absolutely true. Pull a few of the things out. Pull a few of the key levers, if you will.
Something that we're experiencing very regionally is the increase in California. We're very unique. We're very funny in a lot of ways. I think we've got a lot of strengths, and there are a lot of thoughts on various different things. But one of the things that was just passed by legislation is for us to increase healthcare minimum wage to $25 per hour. I am a big proponent of equitable wages. It should be fair. It should be matched to what's in the region. Makes absolute sense. But in healthcare, I feel we're locked in. In any other business or retail space, the increase in cost means that you're going to have to, in expenses, you can increase in what you're going to end up charging. In healthcare, we imagine a patient coming to you and today, oh, now your copay is $50, where yesterday it was $30. We don't do that. We can't do that. We choose not to do that. So how do we offset, again, these rising expenses that legislation is putting on us without having some lever to be able to actually get more funding? Medicare across the United States for us continues to decrease. That's the majority of we, depending on your region, the payer type that's helping to fund your medical practice. All these little things, again, are adding stress to again, trying to provide the best care that you can on a shoestring budget.
Yeah. Yeah. Well, I'd like to dig into a couple of those. And for some reason, when one talks about healthcare systems, a lot of people, well, disagreement is absolutely fine. Being disagreeable is not fine. So I think we might disagree on a few things, but I think that's healthy because it hopefully stimulates debate. And where I want to take this is the differences between the two systems. So as I told you, I trained in Britain and I practiced here. Then I moved to the United States and was there for many, many years. The problems are not dissimilar. The etiologies are slightly different, but the problems aren't dissimilar. In fact, I'd say that we are merely as either, I can't remember if it was Oscar Wilde, George Bernard Shaw, or Winston Churchill who said it, that we're two nations divided by a common language. There are some things that work brilliantly in the British National Health Service. Aortic aneurysm screening. You hit a certain age, you get an email, a text, a card through the mail saying, congratulations, you've reached this age, you're 60 years old, you should be screened for aortic aneurysm. It's free. Click on this link, choose your appointment, and bish bash bosh, you're done. That works brilliantly. No payment at the point of service. That's brilliant. You don't have to worry about paying for stuff because it's all taken care of. There are some things here that are awful. Waiting lists for elective procedures are ridiculous. Some social services have deteriorated terribly over the past few years, and I have my opinions on that. And in America, same for America, great choice of physicians, places, and doctors see, but duplication of services. You can have in one particular city that goes nameless, there are 8 transplant programs. It's ridiculous. It's ridiculous. So you're reduplicating services that aren't necessary. Why? Because it's a for-profit system. So, that leads to very, very, very high prices. In Britain, 16 ibuprofen tablets will cost you about 72 cents. In America, put a 0 on the end of it, right? Over-the-counter medications, bloody ridiculous, absolutely ridiculous. And why can't we learn from each other? And why do Americans have a tendency to sneer at so-called socialized medicine? It isn't socialized, it's just a single-payer system. And why do Brits turn their nose up at privateering? Why can't we, to quote a very famous American citizen, why can't we all just get along?
Doesn't it seem like we're in high school in a lot of
ways?
Does.
It really does.
Right? We're in two different cliques, two different, we could say groups or gangs, so to speak, when we could actually be best friends and learn from each other. I totally hear you, Jonathan. It just seems like in a lot of ways as Americans, we fear losing choice. We feel that it becomes socialized in a lot of ways as a loss of innovation. On the flip side, I see that as I can see also Brits are also worried about losing equity and access if we were to take over kind of what we're doing over here. But there are definite positives to both. And then I feel that is it perhaps the best thing to be able to see if we can blend these two? I don't know how about that we would go to be able to move towards that. But I definitely do hear the positive things, much because we have some friends in the UK on the healthcare system. But I also do hear that, the wait time is extremely long. I would also even push back to say that here in the US, the wait times for certain things are very long too. It's not getting any better. Access continues to be a big issue. And I think if anything, we're starting to see that only those who can pay a premier price are able to get readily and quick access.
The other issue, Laren, is that if with a for-profit health system, maybe the incentives for people to behave in a certain way are not correctly aligned. I mean, there are some protocols, some evidence-based things about how we should treat certain conditions. I mean, chemotherapy should be given, if possible, at home. Why would you want to come to a hospital when you're sick? And in fact, there are savings for doing that. But, specialty medicines in America, there's a fee that gets paid for administering specialty medicine, which drives the price up again. A chap I knew, Bill Cook, who developed a fantastic company, Cook Medical, taught me that if you put the patient at the center of everything you do, innovation, devices, drugs, put the patient at the center, you'll come to the right solution, and everyone will do just fine. Um, I'm a big fan of doctors running a service. I ran my own practice in America with very, very little administrative support, and we were able to see lots and lots of patients extremely efficiently. And because it's a private system, right? If a patient said, I know I need my gallbladder out, doc, but I can't afford time off work, is there any chance you could do it on Friday after work? 100%. I'll book a theatre for 6 p.m. on Friday, 7 p.m. on Friday, 8 p.m. on Friday. It's a service industry. We're serving people.
That's right.
And serving is a privilege, right?
That's right.
So, what would you take from the British system if you could? Because I know what I'd take from the American. I think there's a lot of great stuff in America, frankly.
I would take from the Brit system a lot of the evidence-based protocols that it put into place. And one of the biggest things that I find that the Brit system has really got well, and you can correct me on this, Jonathan, is the mental health aspect. There is, what I've heard at least and read, is that it's one of the leading areas to be able to provide access, more readily access for a lot of mental health issues. That is something we're struggling with here.
Yeah.
And I think that is a definite plus, and that's something we can learn from. How did the Brits do this? How do we actually correct something that is so prevalent right now, and so, I don't know if it's post-COVID, but it is something that we see more and more of.
Well, I can tell you from, I'm not going to give specifics, but I sadly know about this in America. And one area that's terrible is in the addiction space. If you have an addiction in America, you will fall victim to a predatory system, that will bankrupt you. And I saw some of the bills I saw, what the system was charging. One thing, for instance, a daily urinalysis looking for a drug screen, which you can do with a little kit, OTC, costs a few dollars, a couple of pounds over here. They were charging over $3,000 a day to do a drug screen. I mean, that is just grotesque. And that's taking advantage of people at the lowest point of their lives. Yeah, I think they do things, but it could be better over here. But certainly there isn't that kind of profiteering. That would be it would be considered not cricket.
Right.
Don't do that kind of stuff. Well, one thing I'm going to suggest as an outcome, what about if you pull together, because you're a real go-getter, I've seen that in the brief time we've known each other. What if you pulled together like a consortium of doctors from around the world, and we had a conference? Let's bring to the table all the things our systems do well and all the things they do poorly, and let's see if we can't go back to our countries and pin the health minister against the wall and say, hey, pal, here's what you need to do. Let's learn from each other.
That's a fabulous idea.
Well, you're in charge. You're in charge.
Let's bring it up to the EMJ board, and let's see if we'll partner together and take that on.
That would be a hell of a thing to do. So if the EMJ leadership are listening, take that away. So
that's right.
Let's dig down a bit further. How's healthcare going to be sustainable with inflation, cuts, growing? That's another thing, growing populations. Our National Health Service is 75 years old, and it was instituted when there was a much smaller population, a much less diverse population. So we didn't have things like sickle cell anemia wasn't seen. When I was at medical school, I never saw a case, not one through in my entire medical school, because of the population mix. Reduced contributions per capita to budgets. So we got an older population that aren't paying in anymore, and they're living longer and consuming more services. Risks of global pandemics from zoonoses, and on and on and on. Again, Laren, the floor is yours.
Sustainability, going back to the paper, going back to thinking about blue zones, going back to thinking about our communities, is probably one of the things that I do stay up at night thinking about, especially as in my role as chair of medicine here, it's trying to think about our faculty. How do we sustain the practices and the services that we have and provide timely care? Because what we're also facing is a growing population, but that population that's growing are also the physicians. The physicians are also growing and they're retiring too. And we're seeing also a lot of, we could say, those who have started off in medicine but have since pivoted to something else completely outside of medicine. So no longer are we having enough physicians to provide the care that's necessary. I you know, the thought of working smarter, not harder, is so key right now, right? As we leverage artificial intelligence technology, I think the great thing that came out of COVID is telemedicine, to be able to provide more access care from really anywhere if you're allowed to actually bill appropriately for that. One thing, though, Jonathan, that I've thought really deep about is that maybe we have it all wrong. Maybe we actually need to focus more, which is something I think, again, the UK is doing better on, which is on lifestyle medicine, right? We commonly talk about preventive medicine, but okay, is that prevention through vaccines? Is that prevention through, okay, let's get a hemoglobin A1C, let's screen for aortic aneurysm. But if our lifestyle, if we focused on lifestyle, where we have better eating habits,
You
better
mean, Lord
exercise.
forbid, actually have a healthcare system instead of a disease care system, right?
Yes, absolutely. I mean, think about it, right? It's just,
How much is a packet of cigarettes in America nowadays?
last time I checked, about $25 or so,
Yeah,
depending
it's about
upon
the
the
same
brand.
here now. It's about the same here now, and they are taxing sweet drinks.
Yep.
High fructose corn syrup is used far more in the States, unfortunately. And you see it in the obesity rates. I
Yep.
mean, and yeah, I mean, you're absolutely right. Well, I'm in London at the moment, and this city is becoming. I have a trying to drive in London. You've got to be mad to do it anyway. But everywhere they've taken roads and made them almost exclusively bike lanes, so that they have very inexpensive bikes that you can use around the city, and they're trying to encourage people to do it. But I'm conscious walking around here compared to an American city, you see far less obesity,
Right.
which I think you're absolutely right. Well, so given all the challenges we face, what metrics do we use to rate healthcare outcomes? Because we're delivering care differently to different populations. We've got all the challenges that we as physicians are facing. How do we rate the outcomes given these issues?
I think there are various different ways that we could rate outcomes, like many of which we've looked at as readmission rates. I think the government's also looking at, uh, what are the how well are you compliant in doing your screenings, right, throughout the year, and I think those are great metrics. What we're starting to see more of, and it's interesting, at least more discussions, is not necessarily the rate of healthcare outcomes. Where part of that is how are the patients actually rating the physicians or the system itself. That almost seems to be almost bundled also to reimbursements, sometimes even penalties that could be towards the healthcare system or the group itself. And that to me is that is that a good rate way to be able to rate outcomes? I think in part, if you have a compliant patient that is happy with your system, you're going to have a healthier patient. At least that's my thoughts on that. But all these various things coming together are something that we've never really thought of in a lot of ways. We always thought about just disease outcomes, but there is a happiness factor that's also, I think, needs to take.
100%. Patients tend to remember things like what was the quality of the food in the hospital, were the porters polite to them, the transporters polite to them. What was it Sir William Osler said from Hopkins? The good physician should be able, available, and affable. Right, that's
That's
what
right.
patients remember: a smiley face, a firm handshake, a reassuring manner. Um, Another couple of challenges for you, Laren. The cost of medical education is substantial, crippling even. I don't know what the numbers are in America, but when I tell my friends what they used to be at the universities where I taught, they fall over because, university here is between 9 to 13,000 a year. And there is, of course, assistance. Uh, but, a maximum of that if you're not a British subject. And given the amount of time it takes to train as a doctor, and then you get a reduced income once you've graduated and you've got all this debt, and you've mentioned not enough doctors, driving burnout, right?
Right.
Early retirement and other woes. And of course, some doctors can't even afford to retire. In the UK and elsewhere, sadly, doctors going on strike.
That's right.
So, which I find incomprehensible. I couldn't conceive that we ever would have done that. But, when I see what they're being paid, it's like, holy camoli, that's. So, what are your thoughts on those two issues, cost of medical education and the workforce?
Just thinking about cost of medical education, everything you've talked about, it's depressing in a lot of ways because the need is out there, and really what we're looking for is a life of service. And but I feel that life of service shouldn't come at such a disadvantage that you're not able to pay your bills. You're not able to actually live, uh, at least we would say, a happier life based upon your finances, right? And that can be defined in various different ways. The cost of medicine for medical school here in the United States can average anywhere between 200 to 250,000 for medical school itself. What I think a lot of people don't take into account is many actually have, even myself included, which is undergrad loans to get to medical schools. You tack that on, all right? And if we were to just add everything up, let's say it's $300,000 you're coming out at a 9% interest, like that's just the highest that you can. Over 10 years, you'd be paying probably about $3,800 per month. And remember, like what you're saying, right? We all get out of medical school and we're getting paid not at a full attending salary, but at still a trainee salary, which makes sense because we're still learning, still that progression. And it's hard to make a living off of that, let alone have a family with that. Tack on inflation, tack on depending on where you live, the cost of the living. It doesn't seem like even going into medicine is something that is financially pleasing in any way. And I think that's where it's good and it's bad because it comes to those that are just wanting to serve. But again, how do you actually serve when you can't even afford your apartment that you're living in?
Yeah, well said. Well
Right.
said.
So things like we need a better way to be able to decrease the debt burden. So this way it's really less about surviving the debt and more about our physicians or us trying to think about how we're going to save lives. And so these various different things will be very helpful moving forward on how we actually help younger physicians live
Yeah,
a
well,
forward.
the society's got to make some decisions. I mean, I went to university here in the UK. I did not come from a family with any wealth, so there was no tuition. It was covered. In fact, I had a small grant which helped with my living expenses. And that's because the society decides that they want to educate doctors. They want doctors, right? And so it's a societal decision. I commend. I'm not a fan normally of his work, Michael Moore, but he made one of his sort of tongue-in-cheek documentaries, and it was something like, "Which country should we invade next?" And it was all about how America can learn from how other countries do things, um, and it was done with delicious irony. It's actually one of his documentaries that I can watch and not get irritated by. But again, it's an absence of hubris. As societies, we have to learn from each other. Another one for you, and I'm loving this. What are your thoughts on the seemingly never-ending demand for more documentation, or administrivia, as a friend of mine calls it?
And I love that term,
Yeah.
administrivia.
It's
That's
not
great.
mine. Scott
Great.
Parazinski, if you're listening in, kudos, man.
Scott, that's awesome, right? I feel that that burden of documentation is one of the leading causes of just burnout. I it's taken so much away from, hey, I just want to talk to the patient to be able to help them, to let me type everything that you're saying and make sure I'm documenting appropriately so I don't get dinged for, I don't know, something on the billing end of things. I think documentation is absolutely necessary. It's definitely needed, but it's really becoming so cumbersome that unless we get some help or a way to actually decrease on the documentation, it's just the bane of even just trying to practice medicine. It's going, oh, you want to do this? Well, you got to document.
Well, you know something, I would challenge you here. Why have physicians allowed themselves to be bullied into this? Again, I will preserve anonymity, so-called Chatham House rule. Uh, the hospital I was working at, they decided that they were going to do some things to save money, and one of them was they changed our surgical gloves. They didn't talk to us, they just changed. Now, as a surgeon, we're sort of close to Neanderthals. We just communicate by grunts and monosyllabic words. Our hands are really important. And I was at the scrub sink and I was trying to put on a pair of these gloves and they kept breaking as I'm trying to put them on. And I could hear a commotion from just down the way. And one of my more, should we say, animated colleagues was saying, you know, I want my gloves. I don't want this crap. And the nurse was saying, well, we don't have them. This is all there is. And he said, okay, open another pair. And he took them and dropped them on the floor. And I was watching this and he said, open another pair. And he dropped them. And the head nurse came over and says, such and such, what are you up to? And he said, I'm going to keep doing this until the administrator who made this damn fool decision comes down and explains it. And meantime, get me some gloves. There must be some in a storeroom. They were trying to save some money, but instead of actually coming to the physicians and saying, we need to save X dollars from the operating room accounts, how do we do it? They imposed a solution and they didn't know what they were doing. Right? They're not there.
Right.
With your background, would
Right.
you want me making a decision about how to treat patients with respiratory illness?
That's
I
right.
don't know the first thing about it. So yeah, we need to be a bit more vociferous, Laren, and
I, I,
and,
I
and
agree.
own our space. So switching subjects, tell us about your entrepreneurial gene, the Center for Innovation and Promotions, Ignis Medical Innovations, your medtech think tank. Uh, what are some of the focus areas for you?
One of the biggest focus areas for us was to be able to try to collaborate more so and be this garage of medical innovations. And granted, this was very early on when I first came to Loma Linda, and it's really spiraled out into something even now with our practice group. And now we have this group called Creative Innovations, Communication, and Branding, which actually entails a lot of the innovative things with marketing and communications. But we really wanted to be able to tinker around with a lot of academics has a lot of ideas, great ideas, and little things here and there that people have created in their spaces. It's very siloed in a lot of ways, and to be able to connect this with technology has probably been one of the best things that I have truly loved while being here at Loma Linda. A good example is very early on, probably about 5 years ago, augmented reality was a big thing, right? Having a little screen off to the side, it almost seems like you had a big television screen right in front of you, and you could work with your hands and do different things. So we were using that in the teaching space. Can we use augmented reality glasses to do percutaneous tracheostomy in the ICU? We demonstrated that. That was very doable because instead of us having to keep turning your head to look at a screen, and, have I pierced through the front and the back of the trachea? No, I can actually just look still in that surgical space and not ever have to lift my head up because I got this augmented reality glasses.
Heads up display, gotta love it.
Correct, right? Yeah. Intubation. What are the steps going through? We talked about protocolizing things. What are the steps? Have you thought about all these various different steps? Uh, all these various different things. So we were actually publishing a lot of these things. Has it caught on in the medical space? Unfortunately, no, for various different reasons. But we actually showed that proof of concept that this can be done, and we pitched it to various different companies.
Lovely. Well, I think that that's a subject for another day to expand on, because innovation, participating in driving innovation, has been like um, like my lifeblood, because it's like going to the gym for your brain. It's pushing you
That's
to
right.
solve problems and fly. Another aviation term, you fly ahead of the aeroplane. How can you know how can you predict what's going to happen, and how can you manage it better? And that's a joy. Good on you for doing that. Precision marketing in healthcare is one of your interests, I know, and I saw you took a course in email marketing skills. You really are a character. How do you foresee this approach transforming patient care, and how, the internet is an echo chamber for good or bad. How do we use social media more responsibly? My personal perspective is doctors who know should be out front and center, so that we can trample on pseudoscience and people who lack some ethical clarity about what they should be doing in their life, selling snake oil and such like.
That's right.
So yeah, over to you.
Jonathan, that is a tough one, especially in today's society, where it almost seems like the truth is really whoever's most popular is speaking the truth, and that is hard, right? It is something that it's almost like a David and Goliath story, where where David's trying to tell the truth, and you have this behemoth that has got so many followers and saying, no, this is the truth. And I think that's where, as physicians, if we're able to connect better with our patients and also with our community, they will trust us in that. Going back to precision marketing and email, I think email to this point now has caused so much noise that it's hard to actually understand. I don't know if you check your emails. I delete almost half of them before I don't even read them, because it just looks like junk. I don't know what's real, what's not, but I don't have time to sift through everything.
Yeah.
But I think where precision marketing is headed is what everybody has, which is a cell phone, right? And being able to, with our cell phones, there's a lot of data, and whether we like it or not, it's being tracked. It's being what we're searched, and all of these things. If we're able to utilize artificial intelligence, we're able to cater the type of communications to each individual specifically. So, for example, if we notice, going back to lifestyle medicine, right? We notice somebody is actually searching a lot about potato chips. Maybe a little text needs to come up and go, quick reminder, you know, your blood pressure is really high. We have this, cooking, I don't know, let's say cooking class we'd like for you to attend. Sign up, click here. Things like that, I feel, is the way, again, to not just make people aware, but to change their lifestyle to be able to impact our healthcare. In a lot of ways, it ripples out. So this way, we're not getting burnt out doing the same thing over and over again to treat a disease that could have been prevented.
Yeah, absolutely. Um, so my final question for you is one I love to ask. If you had access to a magical genie, and say you're doing a bit of closet running in the desert, and you come across a magic lantern, rub it, and out pops a genie and offers you three wishes, um, what would they be?
Oh, I, Jonathan, I know it's going to be really just silly in a lot of ways, but if I truly, really had those three wishes, and as it pertains to healthcare, it'd be for universal access for healthcare, reduce the cost without compromising the quality that we've been so seeking to provide, um, a robust system that will allow us, you and I, and others that are probably watching this, to be able to continue to innovate and implement it in a way without having so much red tape. Of course, I know why they're there to make things safe, but if we could implement them much faster, I think it'd help us out significantly. And then always try to be able to figure out a way to make things affordable. I think that's so key. So all these things, I know it just seems like just pie in the sky, but it is at least a goal. We can't score unless we have a goal. And if we have that goal, then it's something we can move towards. So that would be my three wishes, John.
Not surprised to hear you say that. It's been an utter delight talking to you, Laren, and I'm looking forward to further conversations and seeing some of those rocks up close and personal. Sadly, that's all we've got time for today. So I'd like to thank Dr. Laren Tan, not only for being with us today, but for everything he is doing to force us to think, and obviously everything he's doing to help save and improve the lives of the patients he looks after. Real pleasure chatting with you, Laren.
Thank you so much, Jonathan. It is just it's humbling to be able to be here, to be able to talk to you and those that are viewing this. And for those that are watching, I know that a lot of times our job is thankless. So I want to thank you for really doing all that you do.
Hear him for taking the time out of their day to listen. So, folks, if you've enjoyed this chat, and I guess if you're still listening, you probably have, please subscribe on Apple Podcasts and Spotify and all the other various platforms. And that way you won't miss an episode. Check out the archives. There's loads of great conversations in there. And tell your friends, tell your colleagues, like us on social media, blah, 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 blah. And please join us next week for another great episode. Until then, I'm Dr. Jonathan. I can't even say my name. I'm Dr. Jonathan Sakia. Thank you for listening to the EMJ podcast. Please, everyone, stay safe, stay well, stay curious. Bye for now.